Our second case today features a 44-year-old man who presented with 18 months of fatigue, arthralgias, night sweats, and weight loss. He had extensive infectious disease and rheumatologic workups, which were all negative, including 2 courses of treatment for tick-borne illnesses. An abdominal ultrasound was performed for fever of unknown origin, which demonstrated a right renal mass measuring 10 by 8 by 10 centimeters. He underwent a CT of the abdomen and pelvis, which confirmed a 10 by 9 centimeter right upper pole renal mass with partial duplication of the collecting system, no lymphadenopathy, and a CT chest was negative for metastatic disease. He had an initial surgery with a right laparoscopic nephrectomy and regional lymph node dissection. Dr. Fu, can you describe his pathology?
Sure. So he had a very high-grade clear cell renal cell carcinoma with 2% sarcomatoid features. So when we say that there are sarcomatoid features in a carcinoma, that typically means we're seeing morphology that is very atypical, high-grade in appearance, often spindled in appearance, and that is generally associated with a poorer prognosis. And so even if it's very focal, we would still report a Furman grade 4.
Great, thank you. 1 year later, he was undergoing staging CT when he had a chest, abdomen, and pelvis CT performed. This showed in the medial edge of the right middle lobe of the lung, he had a nodule that was previously measuring 0.8 by 0.9 centimeters 3 months prior, and that had increased in size to 1.3 by 1.4 centimeters. There were no other definite evidence of metastases. So for this patient, we were hoping to discuss additional staging as well as role for biopsies or metastacectomies at this point.
I'd like to make a comment first about the history. The first question that pops up, I think, for many patients is, at the time of his first surgery, when he had stage 2 high-grade sarcomatoid renal cell carcinoma, was there a role at that point for adjuvant therapy? Should he have received systemic therapy after nephrectomy? And this is a common question that patients ask when I tell them they're at a little bit increased risk of recurrence because of the sarcomatoid features in their tumor. They ask if there's anything that we can give to prevent that. And I was wondering, Mike, if you could comment on that. What do you think?
Sure. No, this is a great question, and this, again, is a question that's commonly asked by patients. Given the activity of drugs like Sutent, sorafenib, et cetera, in the metastatic setting, it could be reasonably wondered maybe we should try to treat high-risk patients to try to reduce the risk of recurrence or at least delay recurrence. So as far as the evidence that is known right now, recently the ASSURE study, which was looking at adjuvant sunitinib or sorafenib, did not show a benefit to adjuvant treatment for high-risk patients with localized renal cell carcinoma. There are multiple other studies, STRAC, Everest, using other agents, including axitinib, everolimus, etc., that have accrued and are waiting to read out. But at least the first results that we have do not support adjuvant therapy at this point, unfortunately, for patients.
Yeah, I think that's exactly what I would tell the patient too. And the other thing is patients with sarcomatoid tumors in general are not generally very responsive to tyrosine kinase inhibition or mTOR inhibitors that we know of.
Right.
So, there's maybe those 2 reasons. As for this patient's lung lesion, it's small, it's unifocal. For me, this at this size, 1.4 centimeters, it might be very difficult to biopsy. Generally, lesions at 1 centimeter in size can be tricky, but I would consider this potentially for a resection. This is a tumor on the imaging that is very peripheral in the lung, and would look to me to be amenable to thoracoscopic wedge resection. So my first thought would be, well, it's a unifocal site of disease. Maybe it can be resected, but before doing that, I'd want to make sure that there was no other disease elsewhere. And for me, that would include a bone scan. to look for disease in the bone. And if he hadn't had a CT of the abdomen and pelvis, but I think he did, I would check that. But if the CT of the abdomen and pelvis was fine, the bone scan was clear, and with a solitary lung lesion, I personally wouldn't scan the brain. I would generally do that when the burden of disease above the diaphragm is high. So multiple or lung metastases is when I would, or multiple lung and bone metastases, that's when I would consider checking his head.
Yeah, no, I agree. And I think certainly in this patient, a metacystectomy would make sense. I think the thing to realize with systemic therapy is that it has real side effects. The progression-free survival, depending on what drug you use, sunitinib, pazopanib might be appropriate in this patient, would be about 8 to 9 months. But during that time, the patient is having side effects, fatigue, hypertension, et cetera, whereas if you could treat the patient with local therapy, potentially do a wedge resection or some other way pluck out this nodule, even if all you did is delay the time to systemic therapy, that would be a benefit to the patient.
Yeah, and for thoracoscopic wedge resections, the recovery period is remarkably quick. Patients leave the hospital usually within a couple of days, and usually within six weeks are pretty much back to baseline, assuming that there's no complications.
So the patient did undergo a right thoracoscopic wedge resection when the pathology showed a 1.3 by 1.2 by 1 centimeter clear cell carcinoma with negative margins. Dr. Fu, do you want to comment on his immunohistochemistry staining?
Sure. So the immunohistochemical findings on the lung nodule showed positive staining for RCC and CD10, as well as some patchy staining for vimentin and anti-cytokeratins, and those are all very consistent with a diagnosis of metastatic clear cell renal cell carcinoma. A TTF1 immunostain was negative, and that was done to make sure that it wasn't a pulmonary adenocarcinoma, and those tend to be positive for TTF1, whereas a renal cell carcinoma would be negative, as this case was.
I think this case demonstrates really the role of metastasectomy in renal cell carcinoma. It also demonstrates the patients that tend to benefit. So metastasectomies tend to work best in people who have lung-only disease versus disease in other sites, although it can be beneficial in those other sites. It tends to benefit patients who have asynchronous recurrence of disease rather than synchronous disease. And it tends to benefit patients who have a low number of metastases, 1 or 2 versus 3 or more. So this patient basically had several risk factors that would suggest a good outcome with metastasectomy. Solitary, lung-only disease.
Thanks very much for that commentary. And the patient has remained without evidence of disease now 4 years after metastasectomy, so he met all those criteria. That concludes this case. Thank you for joining us for this session of the Renal Cell Carcinoma Tumor Board.